we're on time and going to move forward. I think it's never too early to learn nor too late to learn. The too early to learn was emphasized by my granddaughter recently, who was in a first grade art class, and the teacher walked around and looked at her paper and said, "Emily, what are you drawing?" And Emily said, "I'm drawing a picture of God." And her teacher said, "But no one knows what God looks like." My granddaughter said, "They will in a minute." So we're going to learn a lot about inflammatory bowel disease in the next several minutes, having gone from 1947, well, actually 1932, when Crohn, Ginsburg, and Oppenheimer first published their paper, which was presented in Atlantic City before the era of casino gambling. So I assume they had a good turnout. 1947, when azolfidine, sulfasalazine was developed, the 50s with prednisone, and then for many years, nothing. We really kind of tinkered with the medicine and used anti-metabolites along the way, and it wasn't until the 90s that the whole panoply of treatment opened up. We're privileged to have Dr. Shivali Berera, Assistant Professor of Clinical Medicine from the University of Pennsylvania, Perelman School of Medicine. It looks like every school has a name attached to it, and it's good to see that hundreds of millions of dollars are going for medical education, and that's all to the good. We like to showcase at least one rising star at each of these clinical symposium that we have, and we are fortunate to have a rising star from the University of Pennsylvania. Dr. Parkman showed you pictures of stool earlier. Astronomers gaze at the stars, gastroenterologists gaze at stool. So as a stool gazer, I can appreciate the stars. And one of the newest stars on the GI firmament in Philadelphia is Dr. Berera. So we look forward to her talk on inflammatory bowel disease. You need to unmute, Doctor.
Unmuted.
There you go.
Perfect.
Now we can hear you. My ability to read lips is somewhat impaired on Saturday mornings, but
I still haven't gotten the hang of Zoom yet. Oh, 1 year in. Good morning, everyone. Thanks for joining us this morning. I want to thank you, Dr. Lefton, and your wonderful team for this invitation, and I really enjoyed all of the talks this morning. I realized that 1 hour for IBD treatment can be a little bit ambitious, but I've really focused my talk on current disease therapies focused and stratified by disease severity. And certainly if there's something that I don't cover, please feel free to ask any questions that I'll address right after the talk. All right, let me advance my first slide. There we go. So ulcerative colitis is a chronic condition. Therapy is required both to induce and maintain remission. The selection of therapy for ulcerative colitis is based on disease extent, severity, and prognosis. And the main goal of therapy is steroid-free remission. That's very important, steroid-free remission. And remission is measured in 2 ways. Symptomatic remission is the improvement in patient-reported outcomes, whereas endoscopic healing is defined as restoration of intact mucosa without friability. Deep remission is a combination of both symptomatic remission and endoscopic healing and is the preferred goal of therapy. Additional goals are to monitor for disease and drug-related complications. So even if a patient is doing well, we definitely want to follow them closely. And routine visits are needed to monitor for relapse and address health maintenance needs as well. Patients with ulcerative colitis should be screened for coexistent anxiety. as well as depressive disorders. The initial treatment is focused on inducing clinical remission with the restoration of bowel frequency and control of bleeding and urgency. And ultimately, endoscopically healed mucosa is associated with sustained remission, reduced risk of colectomy, and likely a reduced risk of dysplasia as well. Histologic remission is the absence of neutrophils. It's a little distinct from mucosal healing in that it's associated with some improved clinical outcomes, but has not yet been validated prospectively as an endpoint of treatment. So in summary, it's not a realistic goal of therapy, as even patients with quiescent disease will often still have features of chronic inflammation with neutrophils, architectural distortion, expansion of the lamina propria on pathology, which are still detectable even when the disease itself is at bay. So it's very important what the colon looks like as opposed to what's under the microscope overall when you're looking for remission. This is important not to act on if there is some activity on the pathology level, if the colon is endoscopically healed, in the sense that we don't react just to pathology results alone, except in the case of microscopic colitis, which is another topic. Fecal calprotectin can be used as a surrogate when endoscopy is not feasible. When we speak of mild disease, this really pertains to those having less than 4 bowel movements per day with blood less than 50% of the time, mild anemia, and an endoscopic Mayo score of 1 bordering on 2. Our endoscopic Mayo score ranges from 0 to 3. So a score of 1 bordering on 2 is usually mild disease. Moderate to severe includes those with greater than 6 bowel movements per day, frequent blood and stool, anemia, and a Mayo score of 2 to 3. And patients should be hospitalized for medical management if they're having greater than 10 bowel movements per day with continuous blood and significant anemia. And in those settings, patients may require IV steroids as well as possibly rescue therapy, which we'll talk about too. So the first drug we'll mention are the aminosalicylates or 5-ASAs. There are several mechanisms of action proposed for these drugs, including preventing leukocyte recruitment into the bowel and interference in the metabolism of prostaglandins. The 5-ASA part of the molecule is the therapeutic portion, but since it's absorbed very quickly, it needs to be bound to a delivery component so that it can actually reach the colon. The first discovered form of this medication, as Dr. Lefton mentioned, was sulfasalazine, which uses a sulfa component to deliver this 5-ASA bound by an azo bond. Bacterial azoreductase cleaves this azo bond and allows it to release the active 5-ASA in the colon. 1/3 of patients had adverse reactions to this sulfa component, and the main ones are headaches, nausea, and rashes. So a variety of other options are available to deliver the 5-ASA or mesalamine compound to the colon. The main ones are listed here, and I did list the brand names because the generic is mainly just mesalamine. Pentaza and Delzacol are released in the small bowel and colon through a time release mechanism. They also come in granule form, so I do use this in a few of my patients who have concomitant EOE or difficulty swallowing large pills. Azicol and Lialda are delivered in the last part of the ileum and have a pH mechanism of release. They're released at a threshold of 6 to 7, so they're not broken down in the stomach. Dipentum, colazole, and azolvedine are all delivered in the colon by relying on that colon bacteria mechanism to split the bond, which is very similar to sulfasalazine. And then Conaza is a suppository, and Rawaza is an enema, which are delivered directly and topically to the rectum or the left colon, which we'll discuss as well. And all of the oral formulations seem to be similarly effective. So moving on, when we find mild to moderate disease, it's important to know the disease distribution. When only proctitis is found, rectal 5-ASA, which is Conaza, is very effective for both induction and maintenance therapy. I usually use it twice a day for the first 6 weeks or so, and then I reduce the dose to nightly if the patient is doing well. Left-sided or pancolitis should be treated initially with dual route mesalamine from above and below, at least for induction, usually again for the first 4 weeks. And then for maintenance, the minimum dose of oral mesalamine is about 2.4 grams per day. Anything less than this does put the patient at risk of flare or not being in remission. If a patient with mild disease is initially quite symptomatic or not responding quickly to 5-ASAs, in that case, I'll give them a course of budesonide for 8 weeks. And certainly if that's not effective, often a single prednisone course for 8 weeks as well, including the taper. The ASCEND-3 study was a double-blind 6-week RCT, which assessed the non-inferiority of delayed release 4.8 gram per day dose of mesalamine. Specifically, they studied Azicol. And not only was it non-inferior, but significantly more patients who received this higher dose of 4.8 grams per day compared to 2.4 grams per day achieve remission at early remission at weeks 3 and 6. So my strategy is to start the patients on that higher dose of 4.8 grams per day initially. And then after approximately 3 to 6 months, I reduce the dose to a minimum of 2 to 2.4 grams per day if they're in clinical remission, unless I plan to complete a close interval follow-up colonoscopy, at which time I would reduce the dose after confirming that they are in endoscopic remission too. The other strategy for pan or left-sided colitis recommended is dual route mesalamine with both oral and enema therapy for induction. A meta-analysis in the American Journal had shown that dual route mesalamine therapy was superior in both the induction of remission in patients with ulcerative colitis, extending beyond just proctitis. So my strategy in this situation is that if somebody has pan or left-sided ulcerative colitis, I keep them on dual therapy for at least 6 to 8 weeks before a trial off the enema while continuing the oral 5-ASA formulation. And as you can imagine, people don't like to take enemas. So, that's my strategy, is to try and induce them into remission early and then try to take them off of it. And in those who don't tolerate enemas, Kinaza can be suggested as well, although that's really only effective in proctitis. All right, so patients who fail initial therapy with 5-ASAs may require corticosteroids. They can induce remission in ulcerative colitis and provide rapid relief of symptoms, as you know, but they are not for use in maintaining remission. There are several side effects with both short-term and long-term use with steroids. 25% of patients become steroid dependent, and 30% of patients who require steroids ultimately do need a colectomy. There always needs to be an exit strategy for the next step to get somebody off steroids. So you're always thinking ahead. And if disease is mild and the patient was on 5-ASAs or corticosteroids were being used to induce remission, perhaps during an initial diagnosis, remember to use the higher dose of 5-ASAs at that 4 to 4.8 gram per day dose, along with the per rectum mesalamine therapy initially. If response to corticosteroids is suboptimal or a patient requires about 2 or more steroid tapers per year, steroid-sparing therapies with immunomodulators or biologics needs to be considered at that point. So there are a few different steroid formulations. Budesonide has less side effects than prednisone because of less systemic absorption. Entocort is released in the ileum, so it can be used for symptomatic mild Crohn's while adjusting or maintaining or changing their maintenance therapies. It comes in 3 milligram tablets, so it can be tapered as well. Ulcerative is released in the colon and can be used for mild to moderate ulcerative colitis flares. And since it only comes in 9 milligram tablets, I usually use it for 8 weeks while changing therapy or starting mesalamines. Prednisone is more effective for moderate to severe ulcerative colitis and should be slowly tapered while optimizing the maintenance therapy. Now, I won't go through all of these risks, but I think it's really important to highlight the fact that It's very important to transition to steroid-sparing therapies as soon as possible, just because of the risk of corticosteroid use is extensive. In fact, COVID-19 infections have not been shown to be worse on biologic therapy, but certainly steroids are an increased risk for worse infection. Now, for mild Crohn's disease, there's usually no role for mesalamines. The American Journal guidelines mention oral mesalamine has not been demonstrated to be effective over placebo for induction of remission. However, in clinical practice, in mild cases of, the scattered aphtha that you may see, or mild isolated colitis that may appear consistent with indeterminate colitis, which you may be called Crohn's due to some mild rectal sparing, I have used a trial of mesalamines with very close follow-up successfully. Controlled release ileal budesonide, as I mentioned, can be used for induction of symptomatic remission in this setting of mild ileal Crohn's. And these patients, particularly if they don't have significant symptoms and it's just an incidental finding on perhaps a routine screening colonoscopy, they can be treated symptomatically with non-immunosuppressive medications, but I would caution you to have a very, very close follow-up and careful observation. I also counsel these patients to try and modify their risk factors, mainly counseling them not to use NSAIDs and also not to smoke, which, as we know, can increase the risk of flare in Crohn's disease. And if someone's completely asymptomatic and has had these findings, I'll often monitor them initially with fecal calprotectin every 6 to 12 months. And then I would do a colonoscopy and follow up at least at minimum 3 years later, just to make sure that things have not progressed. Important to note that antibiotics, antimycobacterial therapy, methotrexate monotherapy, all of these are not recommended for primary therapy in this setting. So moving on to moderate to severe ulcerative colitis, the time to escalate therapy to immunosuppressive steroid-sparing therapy is when a patient is either steroid refractory, right? Steroid dependent while on mesalamines, or having more than 2 flares per year requiring steroids. The available options for steroid-sparing therapy include thiopurines, which are azathioprine and 6-MP, and these can be used at higher doses as monotherapy, but due to their risk profile and need for close monitoring at these doses, we generally use them at lower doses as adjunctive therapy to anti-TNFs rather than on our own in clinical practice at this time. The approved anti-TNFs for ulcerative colitis are infliximab, adalimumab, and golimumab. And the only anti-integrin approved is vedolizumab, which is gut selective. And the only small molecule JAK inhibitor approved at this time is tofacitinib. And ustekinumab, an IL-12/21 inhibitor, is also recently approved for ulcerative colitis as of 2019. And we'll go through each class of medication. So moderate to severe Crohn's is almost always treated with biologics, with a multidisciplinary approach to tackling complications, which can include abscesses, strictures, fistulas. And I know this is a very, very general statement on the management of moderate to severe Crohn's, but beyond the scope of this talk as far as complications from Crohn's. But please feel free to ask any questions if you have any specific ones. Corticosteroids are effective in the short term for alleviating symptoms, but do not achieve mucosal healing whatsoever. And again, should be used very sparingly. In this setting as well, I use immunomodulators only as adjunctive therapy to anti-TNFs and not on their own. The available anti-TNFs are infliximab, adalimumab, and certolizumab, which is certolizumab is unique to Crohn's disease as far as approval or indication. We tend to choose anti-TNFs as first-line therapy for penetrating Crohn's disease. So I generally don't use vedolizumab as a first-line therapy for penetrating disease. I really stick to infliximab as well as adalimumab. In addition to vedolizumab, natalizumab is another anti-integrin approved for Crohn's disease, which, unlike Entyvio or vedolizumab, is not gut selective. And we'll talk about the risks associated with that. I do want to mention that ustekinumab has been approved for moderate to severe Crohn's disease for a while, and there is no role for other immunosuppressives such as cyclosporin, MMF, or tacrolimus in Crohn's disease. So I want to talk a bit about thiopurines and ulcerative colitis. Thiopurines are no longer favored for monotherapy in ulcerative colitis, and definitely not for Crohn's disease. But I do want to mention that they are effective in both induction and for maintenance therapy over placebo in patients with ulcerative colitis. For the maintenance of remission, 6 studies, which included 124 patients on azathioprine or 6-MP, showed a mean efficacy of about 60%, which really is comparable to our other biologics that are available at this time. Thiopurines are purine antagonists. They inhibit DNA and RNA synthesis. And the main role in my practice is as adjunctive therapy to anti-TNFs to boost anti-TNF levels and decrease antibody production to anti-TNFs, which we'll discuss as well. When used as monotherapy, the therapeutic drug levels are achieved at a dosing of 1.5 to 2 milligrams per kilogram. But when used as adjunctive therapy, a lower dose of even 50 milligrams per day is usually very effective. So you don't have to compound the risk of added immunosuppression with very high doses when you're using it as adjunctive therapy. There are several risks associated with thiopurines, and the malignancy risks may compound with time. Due to the drug metabolism itself, which we'll discuss at the next slide, the metabolites and active component can be associated with both hepatotoxicity and bone marrow suppression. And I mentioned cancer. The overall relative risk for cancer is approximately 1.3 to 1.7 in the general population with thiopurines. And the lymphoma risk is primarily focused on T-cell lymphoma in young men. So I try to avoid using it in this group unless absolutely necessary. And often I'll check an EBV IgG. And if that's negative, those patients have a higher risk of complications from this risk. Thiopurines often need to be discontinued in patients after long-term use due to the development of squamous cell cancers or just to mitigate risk. And before starting thiopurines, particularly if I am using it at higher doses, I do check a thiopurine methyltransferase, TPMT, to know how my patient will metabolize the drug. And it's important to check blood counts and liver tests quite regularly. Initially, I check it every 2 to 4 weeks for 2 months, and then I space that out to about every 3 months. So this diagram could absolutely be its own lecture, and Up to Date has a wonderful summary of this if you want to read through it on your own time and at your own pace. But I do want to highlight a few things in the metabolism of thiopurines. It's important to understand that when using thiopurines at any dose, but particularly at therapeutic dosing near the 1.5 to 2 milligram per kilogram, this pathway will tell you exactly how your patient would develop bone marrow suppression or hepatotoxicity. So azathioprine is metabolized to 6-MP in the liver by a non-enzymatic pathway, so you can really give either drug. Generally, I would just stick to one or the other in your clinical practice. The active metabolite is 6-TGN, and when these levels are too high of the 6-TGN, patients can develop bone marrow suppression. So we check that TPMT, the thiopurine methyltransferase, which is responsible for breaking down 6-MP to 6-MMP, which is a metabolic product that can cause hepatotoxicity. You can see it on the bottom left here. So in summary, if somebody has a high TPMT activity, they will be at higher risk of hepatotoxicity because they'll be metabolizing more of the drug down to this 6-MMP component. And if they have a low TPMT, they're at risk of bone marrow suppression because the 6-TGN levels will skyrocket. So therefore, in patients who have increased TPMT and they end up having this high hepatotoxic 6-MMP level, you can give them less drug, right? A lower dose of the thiopurine. And you can also add allopurinol, which is a little trick which blocks the xanthine oxidase activity, which channels the metabolism toward higher therapeutic levels of the 6-TGN and away from the toxic, hepatotoxic metabolite. All right, so moving on to anti-TNF therapy. For the purpose of this talk, I'll focus mainly on the two oldest and most used anti-TNFs, infliximab and adalimumab. Infliximab is chimeric, meaning it's made of mouse and human, and adalimumab is made completely of human IgG1. It's an IgG1 antibody. Infliximab is given via infusion at standard induction doses of 5 mg per kg at 0, 2, and 6 weeks, and then every 8 weeks, whereas adalimumab is subcutaneous, and the standard dosing is a higher dose of 160 milligrams in the beginning, then 80 milligrams, and then 40 milligrams every 2 weeks is standard dosing. Golimumab is another anti-TNF approved only for ulcerative colitis, and certolizumab is only approved for Crohn's disease. And certolizumab was a very notable drug when I was in fellowship because it does not cross the placental barrier. So this was, preferred for women of childbearing age who had plans to have a baby quite soon. However, now that Uma Mahadevan's study in pregnancy for biologics has shown, the piano registry is what it's called, has shown that biologics are very safe with good outcomes with Crohn's disease. We actually don't tailor our biologic choice to whether or not a woman has childbearing plans. Because the safety data is actually very reassuring for both thiopurines and for biologic therapy. So unfortunately, this slide shares that not everyone responds to biologic therapy. And when they do, often people lose response. So the ceiling remission rate for all biologics is about 60%, which is not that great. But when it works, it does work well. For anti-TNF therapy, the week 54 remission rates are between 50 to 69%. And the sad part is that nearly 40% of those patients will lose response after 1 year. And if someone has lost response to an initial anti-TNF, they have a lower response rate to other anti-TNFs. Immunogenicity, which is the term that we use to describe antibody development against biologics, is a major cause for loss of response. The rates of this increase with time, unfortunately, and it's thought that if the levels of biologics drop below a therapeutic range, that the body has an opportunity to recognize that this drug is foreign and basically attack it. Higher drug levels are associated with less immunogenicity, so this is one of our goals as well, to make sure that the drug levels are in therapeutic range. Immunogenicity is a major issue with anti-TNF therapy, but in general, other biologics like your anti-integrins or IL-12/23 inhibitors do not seem to be nearly as immunogenic. If someone loses response due to antibodies, you can switch to another anti-TNF. But if someone loses response without antibodies, I do recommend that that patient may not respond to other anti-TNFs in general, and you may want to try another class of medication next. Immunogenicity is another reason why biologics, particularly anti-TNF, should not be started and stopped. So whenever a patient, asks me the question, hey, can I stop this medication and see, what happens over 6 months and perhaps restart it if I start feeling bad again? I always counsel them that there's a high risk of a drug reaction given by antibodies after a second exposure, after a prolonged gap in therapy. So we only re-expose patients to an anti-TNF that they had been on before in very specific circumstances with very close monitoring of antibody levels and steroid pre-meds to avoid infusion reactions. Risks with anti-TNFs include allergic reactions, infection, heart failure, and liver injury, drug-induced lupus, demyelinating diseases, and cancer. These are all contraindications to therapy, and patients have to be screened for hepatitis B and tuberculosis before starting due to a higher risk of reactivation if they do have prior infection. This slide was adapted from the recent AIBD conference in December of just this past year, and it's about therapeutic drug monitoring. So I really only use therapeutic drug monitoring for patients on anti-TNFs and sometimes vedolizumab. Everyone has a different practice strategy, and I like to check levels even if someone's doing well, which is called proactive drug monitoring. And this is certainly an area of debate amongst gastroenterologists. I usually check it every 6 to 12 months initially because I feel that if the drug levels are dwindling down to a low range, or if someone's developed low-level antibodies, I would rather proactively do something about it before it's too late and high-level antibodies have been formed. The goal drug level when a patient has good disease controlled for anti-TNFs is approximately 5 to 10 for both infliximab and adalimumab. If someone has uncontrolled disease or fistulizing or penetrating disease, I aim for a goal level of greater than 10 in those patients. And there are several ways to increase drug levels for infliximab, which include either increasing the dose concentration, shortening the drug interval from perhaps every 8 weeks to every 4 weeks, or adding immunomodulators, which we'll talk about next, as adjunctive therapy. The minimal interval for infliximab is every 4 weeks, but the dose itself can be given up to even 15 mg per kg with insurance approval and close monitoring. If the levels are in good range, higher concentrations of infliximab are not associated with increased drug toxicity. But certainly if I check a level and it's above 37, I do try to scale back on the dose. Adalimumab can be given weekly instead of every 2 weeks, but since there isn't a lot of drug in one pen, sometimes patients do need to be reinduced a few times before getting possibly weekly dosing to try and get higher drug concentrations. And for this reason, I tend not to use it in severe ulcerative colitis because I just don't feel that enough drug can be administered, especially when the albumin levels are low. But otherwise, it's extremely effective in other situations. Vedolizumab drug levels are sometimes helpful, but I find it very difficult to get insurance approval for a higher dose than 300 milligrams every 4 weeks, which is really the only move you can make from 8 weeks to every 4 weeks. So you can really decide this based on the clinical picture alone, but it would be helpful to know if somebody's not responding at all, have they developed possibly antibodies? And I do have a handful of patients who are on 600 milligrams every 4 weeks, but it does require quite a bit of insurance battling. So moving on to combination therapy, the SONIC trial, which I encourage you all to re-review if you haven't recently, showed combination therapy with infliximab and azathioprine resulted in significantly higher remission rates in Crohn's disease. Combination therapy has also been shown to reduce immunogenicity, and this was more recently confirmed with a large UK study called PANTS, Personalized Anti-TNF Therapy. The mechanism behind this is unknown, but it is known that by adding a thiopurine to an anti-TNF, it boosts the levels of the anti-TNF. And like I mentioned earlier, if the levels are adequate or high, it's a lot more difficult to create antibodies. And often low-level antibodies can even be overcome by the addition of an immunomodulator, such as thiopurine. A 2018 study showed that in those who had failed adalimumab because of antibody development, using combination therapy with azathioprine when starting infliximab significantly lowered the rate of immunogenicity. So as far as my clinical practice, if somebody has developed antibodies to their first anti-TNF, I use combination therapy in the future with their second anti-TNF because you know that the patient is prone to developing antibodies. The COMET study did not show significant benefits with methotrexate combination therapy, especially in ulcerative colitis, but it is used often as adjunctive therapy to anti-TNFs in patients with Crohn's disease. It's very important to counsel patients on birth control, obviously for your female patients, because methotrexate is teratogenic, and it's important to give folic acid along with it. And because it all seems to be about levels, I don't want to not emphasize that optimizing anti-TNF monotherapy itself is often the first goal of therapy. And that allows you to avoid additional immunosuppression with a thiopurine if you're already giving good dosing of your anti-TNF. So moving on to our anti-integrin therapy. Vedolizumab binds alpha-4 beta-7 integrins, which are on T lymphocytes. I know that this is a little bit in detail, but it binds to MADCAM. And the reason why I mention it is that this is a mucosal adjacent adhesion molecule, which is only present on the surface of mucosal endothelial cells. And so it's a crucial component of why vedolizumab is only gut selective. And because it's gut selective, vedolizumab is considered the biologic with the most favorable safety profile. Its dosing is not weight-based. It's 300 milligrams at 0, 2, and 6 weeks for induction, and then usually given it every 8 weeks. But as I mentioned, I often increase the dose frequency to every 4 weeks to recapture non-responders. The main downside to vedolizumab is that it has a very relatively slow onset of action. It can sometimes take even up to 4 to 6 months for effect, and often patients flare while you're trying to optimize their therapy. So it is important to counsel your patient and assess on your own end if you have enough time on your side to allow vedolizumab to take effect. And because it has low immunogenicity, it's not common practice to use combination therapy with anti-integrins. And I'll also briefly mention one other important point about natalizumab Tysabri, which I mentioned earlier, because I don't use it very often, but I did have a handful of patients on it during my training. And it is very important to note that because it binds both alpha-4 beta-7 and alpha-4 beta-1, that it's not gut selective because alpha-4 beta-1 is found in the CSF. And therefore, patients are at risk of progressive multifocal leukoencephalopathy. And what that is a viral opportunistic infection caused by the JC virus. So if you do have any patients on natalizumab, it can only be used if the antibody to JC virus is negative. And for monitoring purposes, this should be checked every 6 months, and the drug should be discontinued if that antibody to JC virus ever becomes positive. Moving on to our newer member of the family, tofacitinib for ulcerative colitis. It's an oral small molecule JAK inhibitor approved for moderate to severe ulcerative colitis. And there's a lot of data, even though it's new on our end, a lot of data for our rheumatoid arthritis patients. The dosing is 10 milligrams twice a day for 8 weeks. And then we try to attempt a dose reduction to 5 milligrams twice a day. It has a relatively quick onset of action, which is very desirable. And both doses, the 5 milligram twice a day and 10 milligram twice a day dosing, are efficacious for maintenance therapy. The most important risks to be aware of are an increased risk of shingles, but fortunately we have the very effective dead Shingrix vaccines. So I often recommend that my patients try to get vaccinated as soon as possible if we are planning on starting tofacitinib. And I have had some success in getting the shingles vaccines, even for my patients under the age of 50, just because I put some time into writing a letter that I use for insurance companies and to pharmacies as well. The other risks are possibly non-melanoma cancers, elevated cholesterol, of which the significance is really unknown, but we do often check LDL levels, at least for the first year, just for monitoring. And notably, pulmonary embolus risk was notable in RA patients, but not IBD patients at the 10 milligrams twice a day dose. So because of this finding, my clinical practice is to try to reduce the dose after 8 weeks to 5 milligrams twice a day. But I will say that often our patients who are now on tofacitinib have already failed 1, 2, or 3 drugs. So, I don't want to ignore the fact that often reducing the dose to 5 milligrams twice a day often can cause a flare. And in that case, I just discuss the risks and counsel my patients and go back up to the 10 milligram dose if needed. Now, ustekinumab binds to the P40 subunit of IL-12 and 23 and prevents their interaction with cell surface receptors. This inhibits cell signaling and the activation and production of cytokines. It's approved for Crohn's disease and as of 2019, also approved in patients with ulcerative colitis. It overall has low immunogenicity too, so I often give it as just monotherapy. And risk counseling is similar to the other biologics that I mentioned without any particular risks that are very unique to ustekinumab itself. I took this slide from Millie Long, which she presented at AIBD in December of 2020 as well, because I do want to spend a little bit of time on medical salvage therapy for a patient admitted with acute severe ulcerative colitis. Because I know that the medicine teams have to monitor these patients and certainly the inpatient teams as well. And these patients require a lot of close monitoring. So we'll go through this algorithm somewhat step by step in the next few slides, beginning with the initial assessment of a hospitalized patient with acute severe ulcerative colitis, and then moving on to medical management strategies concurrent with a colorectal surgery consultation. So before discussing medical management for the patient who's admitted with acute severe ulcerative colitis, which, as we mentioned in the first slide, I think is greater than 10 bowel movements per day, bloody bowel movements, and certainly anemia. So infectious causes are very important to be excluded, especially Clostridium difficile. A FACG should be arranged as part of the initial evaluation. This can be unsedated and unprepped. And the main purpose of that is to get a baseline activity as well as to rule out CMV colitis. Cytomegalovirus is very important to rule out because it can mimic acute severe ulcerative colitis or be the sole cause of a flare. It's also important to get baseline labs, including a CRP, blood counts, metabolic panel, and a nutrition assessment. It's very important to know that albumin too. And if there's any change in abdominal pain or exam, I get at least an upright abdominal x-ray to rule out megacolon or perforation. I remember very clearly in my first year of fellowship, I had a patient who told me that she felt absolutely wonderful on her IV steroids. And I thought, yes, thank God, she's going to go home. She's not going to need a colectomy. Everything's going to be great. And I examined her and her abdomen was distended and tympanic. And I got an upright x-ray right away. And she had actually perforated. So just remember that IV steroids can really mask symptoms and make people feel almost like they're on a high, that they feel very well and have a lot of energy. It's important to discontinue medications that can precipitate toxic megacolon and make sure that the patient receives pharmacologic DVT prophylaxis due to a much higher risk of DVT risk at times of flare. And I'll emphasize that that's even in your bleeding patient who's having ulcerative colitis and every bowel movement is bloody. As long as their hemoglobin is stable, it's very important to still continue pharmacologic DVT prophylaxis and not stop that. And then you have to start planning ahead with a quantiferon gold and those hepatitis B labs so that a biologic therapy is not delayed, and consult surgery early on so that an in-depth discussion can be had. And I start steroids the moment the C. diff result returns negative. So moving on to steroids, after introduction of steroids in 1955, the mortality rate from acute severe ulcerative colitis dropped from 50% down to 1 to 2%. The daily dose should be 60 milligrams in a day. Every institution and gastroenterologist does this very differently. I feel that 20 milligrams IV every 8 hours is tolerated well. And CRP should be monitored for downtrend daily. And on day 3, a careful assessment of response to steroids is needed in terms of the CRP as well as in terms of stool frequency. And if the patient is not doing well, possibly repeat a radiograph as well. No response is when the patient persistently has greater than 8 bowel movements per day, a CRP above 45, and continued bleeding. And of the 1/3 of patients who don't respond to IV steroids by day 3 to 5, the risk of colectomy rises to 85%. So in those who have some response, the options are either medical therapy, which we'll talk about next, or still colectomy. Now, in the acute colitis trials, the colectomy rate with infliximab reduced significantly with the 10 mg per kg dose. And the main point of this slide is if you're using rescue infliximab in the inpatient setting, you should only use that higher dose of 10 mg per kg. And I'll explain why as well. The main thought behind this is that patients with acute severe ulcerative colitis, number 1, have very severe disease, and number 2, a low nutritional status, meaning low albumin. And because infliximab is bound to albumin, not only is a lot of the drug lost and shed in the colon, but it's also consumed rapidly by the abundance of TNF in very inflamed tissue. Standard infliximab dosing, like I mentioned in the outpatient setting, is usually given at 0, 2, and 6 weeks, but this is often not enough if the patient has true severe ulcerative colitis, where an accelerating dosing regimen is recommended. So I usually don't give the first 2 doses of infliximab any closer than 5 to 7 days apart, and it is really based on clinical judgment. But the rate of colectomy was reduced with an accelerated dosing regimen as opposed to the standard 0, 2, and 6 week dosing. So as I mentioned, a positive predictive value predictor for successful induction was also the higher albumin in addition to this accelerating regimen. So usually what I'll do is I'll give that 10 milligram per kilogram dose on day 3 if they're not doing that great on IV steroids. And then I'll see how they do. If that CRP drops a lot, you'll likely be successful in discharging the patient and allowing them to get infliximab as an outpatient. But certainly if that CRP starts rising again or symptoms start recurring, I'll give that second dose of infliximab 10 mg per kg at day 5 or even at day 7 or so. All right. If there's no response in 7 to 10 days, I recommend surgery. Remember, risk factors for surgery are prior steroids use, ulcerative colitis duration of less than 3 years, a baseline CRP of greater than 20, and a clinical Mayo score of greater than 10. If some response and relapse, you can proceed with that accelerating dosing, as I mentioned. Only once steroids are successfully transitioned to oral and the patient's clinically stable can they really go home safely. And keep in mind, the gut is very leaky and sick patients' albumins are low. So this graph really does show the significant fecal shedding of that infliximab with the first dose when the colon is very inflamed. And these are patients who, even on discharge, I would keep on a very short interval maintenance dosing of 10 mg per kg every 4 weeks. And I would even consider dual therapy with azathioprine on discharge, just to make sure that I've boosted those infliximab levels as much as possible. Or an alternative thought, now that we have them available more readily, is that you can check an infliximab mid-induction level. And if the levels are on the low end, and usually a mid-induction level of less than 20 or so is considered low in my mind, at that time you can proceed with high-dose infliximab therapy along with an immunomodulator too. And my personal practice is to treat patients with dual therapy for at least the first 6 to 12 months before reassessing if I can maybe remove that immunomodulator. Patients are able to avoid colectomy at least initially, but 50% go on to require colectomy at 2 to 3 years still. So remember that unfortunately loss of response to biologics is about 50% at 1 year. I also try to get my colorectal surgery team involved early, the moment I start somebody on IV steroids, just because I find that, you know, having a very thoughtful discussion and introducing the colorectal surgery team to the patient earlier causes a lot less anxiety than having them meet their surgeon when it's too late. I won't spend too much time on cyclosporin because we don't use it too often, but I do want to mention that if your patient has already been exposed to infliximab, And there's really no option for infliximab rescue therapy. Cyclosporin may be used as salvage therapy as well, but due to toxicity, cyclosporin can't be given at these high doses at home without monitoring naturally. So it can really only be used as induction therapy or a bridge. The first study examining cyclosporin salvage therapy was in 1994, and it had used a dose of 4 mg per kg, but later no difference was found between the 4 mg per kg dose or a 2 mg per kg dose, which is helpful to minimize toxicity, of course. Overall initial response range, initial response rates range between about 64 to 84% in the acute setting. And about 72% of those patients were able to retain their colons at 23 months, and colectomies could be delayed by 6 months. The main side effects to be aware of with cyclosporin are neurotoxicities, including seizures and paresthesias. And it's very important to regularly monitor magnesium, cholesterol, and neurologic exams if you are going to use this strategy. Because cyclosporin is transported by the LDL receptor, it can therefore be toxic or have increased immunosuppression if the low total serum cholesterol levels are low, which is why we monitor that. So the main purpose for this slide is just to emphasize that, well, if somebody fails infliximab rescue therapy in the inpatient setting, you might ask, can I try cyclosporin next? And the answer is no. Unfortunately, patients who were not responding to infliximab or cyclosporin salvage therapy, crossing over to the other drug worked only in 1/3 of patients, but it came with a severe infection rate in 16% of patients, making crossover therapy very dangerous. Head-to-head studies for cyclosporin and infliximab showed no difference between the two, but the head-to-head studies had examined a 5 mg per kg infliximab dose, which, as I mentioned, is too low for the inpatient setting. Also, we're no longer in the practice of using thiopurine monotherapy in patients with severe ulcerative colitis, and cyclosporin was really used as a bridge to these thiopurines in the past. So now there have been some or a few case reports of cyclosporin being a successful bridge to other therapies that we have available, such as vedolizumab or ustekinumab as well. There have been a few case reports for tofacitinib for successful salvage therapy, but I will note that it's not available in the inpatient setting and larger studies need to be done. Tofacitinib does have a rapid onset of action, so this may be an option for patients who can't get infliximab in the inpatient setting in the future. And I also want to mention, while we don't use hyperbaric oxygen therapy in clinical practice either for acute severe ulcerative colitis at this time, there are ongoing studies that have shown benefit with reduction of need for immediate colectomy. I would like to end my talk by just mentioning a few points that are important, I think, especially in this year, about COVID-19 and IBD therapies. The SECURE IBD trial has shown that the risk factors for severe COVID-19 and IBD patients include increasing age, greater than or equal to 2 comorbidities, systemic corticosteroids was the major risk factor, and for some reason that we don't understand because it's not immunosuppressive, sulfasalazine or 5-ASA formulations. Anti-TNFs notably are not associated with more severe COVID-19 infections. So it's very important to counsel your patients and reassure them about that. And later on, a study that was just published in Gut showed that there are no differences between the biologic classes as far as this risk. So anti-TNFs and all of our biologics have shown to be relatively safe, even when somebody is infected with COVID-19. Combination therapy and thiopurines may be associated with an increased risk of severe COVID-19. And please encourage all of your patients to stay on their steroid-sparing therapies because, as I mentioned, corticosteroids have the highest risk of severe COVID-19 infection. And please register your IBD patients with COVID-19 in the SECURE IBD registry. I've given the website right here. I just wanted to mention that the ioibd.org has been a very useful resource to me this entire year. It's the International Organization for the Study of IBD, and it's chaired by my own mentor, Dr. Maria Abreu from the University of Miami. And so I would encourage you to visit that website if you have any questions in the future about COVID-19 or any of the ongoing or more up-to-date data. I think this is my last slide. I wanted to mention the newer studies that have just come out very recently. I'm sure that everyone has been alerted to them about COVID-19 and vaccine response as well. Some discouraging data came out from a UK study of 7,000 patients in whom they had a confirmed COVID-19 infection. And it showed that patients on infliximab had an attenuated serologic response to the COVID-19 infection, meaning that they did not develop antibodies for protection compared to people who were not on infliximab. And this really made us wonder, does that mean that patients who are on infliximab will not respond well to the vaccines and won't build that serologic response that they need? And fortunately, there's another study, which I'll plug right now too, called Prevent COVID. And so far, just over 3,000 patients have been enrolled. And nearly 1,000 of those patients are on infliximab. And thank God, 90% of patients have positive titers to the vaccines. So that's very promising. This is not based on any data at all, but just from a clinical practice standpoint, I'm encouraging all of my patients who are on infliximab or biologics in general to go for the 2-dose vaccines that are available. And I'm really strongly encouraging them to get both doses of vaccines. And you can visit this site, the ibdpartners.org, which I believe is out of UNC, for the most up-to-date data. They're updating it regularly to see how patients are responding to vaccines. Last, wanted to mention, and I won't go through these in detail just because of time constraints, but there are some new agents in phase 3 trials for both Crohn's disease and ulcerative colitis. They include the anti-IL-23 inhibitors, the JAK inhibitors, and the sphingosine 1-phosphate modulators as well. And I'd be happy to answer any questions at all that you might have. Thanks for joining us today.
Thank you for that excellent lecture. And you are encouraging your patients to get the vaccine, as I have my patients call me and say, should I get it? And I say, get it, please get it right away. So we're in agreement. Are you finding it difficult at all to get sulfasalazine, mesalamine medications? I have found recently that some of the insurers are balking or setting up roadblocks to patients. Have you found that the case also?
I'll find that sometimes with Lialda, I tend to order Lialda first just because it's a larger quantity of drug in one pill. So instead of somebody taking 8 pills per day, they can take Lialda 4 pills per day, which is equivalent to 4.8 grams. And sometimes I will get that rejected, and I'll just switch them to Pentasa or Azicol. I haven't had an issue getting Azicol approved recently, or Pentasa.
I had some problems, and I still don't understand why. And just wondered what your experience is. But the insurance companies don't want to pay for anything, so
that's true.
That's part of the drill, I guess. Unfortunately, there are several people that are on the course that didn't register, and we only have phone numbers on you. If you would register, we can be able to include you and get the CME credit for this. Again, visit our website and please click on our supporters, our sponsors, because without them, we would not have this lecture. This lecture series, from my standpoint, was excellent. We started strong, in the middle we were strong, and we certainly ended strong. So I appreciate that. And I've already thanked Dr. Nandi for his recommendation. Dr. Berera. Dr. Ortiz wants to make some comments, and please take the floor back.
Thank you very much, Dr. Lefton. So I want to thank Dr. Lefton for incredible curricula. I have learned a lot. You know, some people might ask, why a psychiatrist is here? Well, let me tell you a story. You know, I'm a consultational liaison psychiatrist. I have collaborated with Dr. Parkman in the hospital. And I'm amazed, you know, how many of these gastroenterological conditions can present with behavioral manifestations, you know, fatigue, brain fog, anxiety, depression. And, you know, my knowledge continues expanding. And with these presentations, I'm learning more and more and more on when to reach out and advocate for my patients so they can get the help that they need when there's a suspicion of a gastroenterological condition that's developing. So thank you very much. I want to thank our sponsors. I want to thank the Philadelphia County Medical Society staff, Aileen, Ryan, Robert Mayamoto, and Mark Osteberi, because these programs take time to be organized. So thank you very much for your time. I want to thank the Education Committee. I want to thank the speakers, Dr. Parkman, Dr. DiMarino, Dr. Sass, and Dr. Berera. So thank you very much for your time. Excellent presentations. I want to remind the audience that Philadelphia County Medical Society has several programs coming up. Please, you see them now here in our presentation. Please enter to our website, philadelphiamedsoc.org/events, and sign up. We're a community strong together. Thank you very much for this excellent morning.